Do you realize that you can treat type 1 diabetes with far less insulin that you are told that you should use? If not, then you should watch this video. It's actually in two parts. One video will be talking about the traditional management of type 1 diabetes, and in the second one we'll come with an alternative solution to managing type 1 diabetes where you can use far less insulin and you have far less fluctuations in your blood glucose levels. I'm Dr. Mazhar. Do subscribe to our channel, click the notification bell so that you're updated with our videos, and do share this video with your friends and family. If you want us to make a video on a certain subject, do let us know, we'll look into it. So before we start, this video is just for general information. This is not personalized medical advice, and you should consult your doctor, your primary care physician, before you make any changes in your treatment plan. Diabetes should be managed by someone who's knowledgeable in the area rather than just taking it from any videos, so it's not personalized medical advice. Okay, so the traditional management of type 1 diabetes is insulin according to the carbs intake, also called carb counting, and also in the terms of what food we eat. What is commonly recommended is fruits, vegetables and whole grains, and less animal products, less fats, less butter and less full fat dairy products. Also frequent advice is that you take 3 main meals and 3 snacks so that you don't take a great amount of calories in one go. So apart from that, physical exercise and activity is also recommended. I've taken this suggestion for a breakfast from the Diabetes UK organization. Now, they recommend you take one of the following: either a bowl of cereals with skimmed milk, whole grain toast with spread and with jam, yogurt and fruit, a cereal bar and a glass of milk. It's quite clear that it contains a good amount of carbohydrates, and what the suggestion is then that you adjust your insulin dosage to the carbohydrates that you're taking. We have the same situation with the lunch. We have chicken or ham sandwich suggestion, a small pasta, salad, soup and a roll with a piece of fruit and yogurt. Keep in mind that the pasta is all carbs. The sandwich and the chicken or ham sandwich is a great deal of carbs, and one piece of fruit and a yogurt, also plenty of carbs. Now, one apple contains 4 teaspoons of sugar, keeping in mind that the blood holds 1 teaspoon of sugar in the whole bloodstream, and if it gets any excess of that, it starts pushing it away to other places in the body, other cells, so that it doesn't float around in the blood circulation. So here we got again a good deal of carbohydrates that are being suggested along with the fruit and yogurt, which are also containing carbohydrates. For the dinner, the Diabetes UK has a number of suggestions. Again, we have in nearly all of these a good amount of carbohydrates, and noodles are hardly anything but carbohydrates. So these rice the same. So these suggestions again are focused on having a good amount of carbohydrates and then adjusting the insulin dose accordingly. So that's what is usually done, and there's an insulin to carbs ratio. Every person would have an individual response to their insulin injections. It could be that 1 unit of insulin does away with, say, 8, 10, 12 or 14 or 18 grams of carbohydrates, and you then adjust your insulin dosage to the amount of carbohydrates you take. Say if you have an insulin carbs ratio of 14, then you take 5 units of insulin to cover for 70 grams of carbohydrates. This may also change within the same person with time, depending on what the situation is. It may be that at some point they may need more units to cover for the carbs they're taking, and at other times they may need less, depending on a number of factors. It could be physical activity, it could be their weight and other factors. Now, the problem with the insulin carbs ratio model is that there's simply too many places where it can go wrong, where we simply do not get it right for good reasons. For instance, food manufacturers allowed up to a 20% error in the carbs labeling. So that is a factor that we need to take into account. And the insulin absorption, or the insulin that actually reaches the cells where it needs to do what it does, can actually vary from an injection up to 25%. And with this, and keep in mind that the American Diabetes Association recommends 60 to 75 grams of carbs per meal. That translates into somewhere around 200 grams of carbs per day. Now, the problem of doing it this way is, say if we go with the ADA recommendation of 75 grams per meal, 75 grams of carbs per meal, and a patient knows from experience that he should take 20 units of insulin for managing 75 grams of carbs. Now, as we just discussed, 20% is allowed, 20% of error is allowed within the labeling. So if the manufacturer says, well, we have a situation here with 75 grams of carbs, 20% off makes it 60, and a 20% addition makes it 90 grams of carbs. So although the label says it's 75 grams, it could actually be anywhere between 60 to 90 grams. So let's work with these three numbers. The middle one that's actually on the label, let's work with the lowest possible and the highest possible within the 20%. Now, even this is what is allowed. Even food manufacturers are not so precise in their contents description. It could even vary beyond this, but let's keep it simple. Now, if you take 20 units of insulin, it could vary up to 25% how much actually reaches the body and does what it needs to do. So 20% off from 25% off from insulin 20 units would make it 15 units. And it could be it's not fully 25%, maybe it's just 15%. So I've given three scenarios here. Say if you take 75 grams of carbs, what you think is 75 grams, it could be it's just 60 grams. And if your insulin intake is actually 25% less than you were taking, well, then you would reach around your target. The same if it's like 15% off, you would still be reaching your target. And of course, if you take the insulin and the carbs and the absorption is 100% and the carbs are correct, in that case you will also be able to reach your target somewhat. But say if it only contains 60 grams of carbs and you're taking 20 units of insulin and all of it is absorbed, in that case we are looking at hypoglycemia. If it's 90 grams and you're taking everything you should take, you could be looking at hyperglycemia. So that is a problem, even if you do it very cautiously and you really make sure that with each meal you take what it says on the label, you take the insulin according to what it says on the label, you measure everything, you're really particular about it. Even that, you cannot always get it right. So because the carbs intake and the insulin dose varies greatly, it's simply not easy to get it right, even if you're very cautious. Now, the other problem is there's no distinction in this model, there's no distinction between carbs. So whether you take a portion of rice, whether you take carbs from green leafy vegetables and carbs from an avocado, it's just put into the same category, it's carbs, you adjust accordingly. Now, the other problem is then, if they don't distinguish between the carbs, the absorption after having boiled rice and the blood glucose level spikes much sooner than if you were to have green leafy vegetables. So you have to take that into account. You have to know what is not only how much carbs does it contain, also how long will it take for the body to actually show the spike from the carbs. So what happens is ultimately with the traditional treatment is that with the insulin carbs ratio is that basically you deal with the hyper and hypoglycemia all the time. You may be too high, you may be too low, and getting it right is just not easy. And you have this roller coaster going on, up and down, and you're trying to keep track with it. And that's a very common scenario with diabetes. But there's a philosophical side to this, so maybe a logical question we need to ask ourselves. Why would we take insulin according to how many carbs we have? If we agree more or less to some extent that carbs to a large extent for a diabetic patient is poisonous, it's not really something we want in our body if we can manage without it, because then we can avoid having the hyperglycemia, we can avoid the hypoglycemia, and we can actually function much better, and the complications from type 1 diabetes can go considerably down if you can keep the blood glucose level within a small band, very small fluctuations. Then we can actually live much longer, and we can actually live much healthier and have less complications. Now, an average type 1 diabetic patient lives 20 years less than the others, the general population. That's quite a remarkable difference, And rather than adjusting the insulin to the carbs, we should maybe consider doing the opposite, trying to absolutely minimize the carbs and then use minimum amount of insulin to have less spikes. Of course, I do know there's a misconception all over the world nearly that maybe for the brain you have to have carbs, and it's said many places that you need carbs for your brain to be working properly. But that is actually not the case. There are two tissues in the body that needs glucose, which is the red blood cells, and tissues within the eye need blood glucose to be at appropriate levels, but the rest of the body doesn't really need it. Now, you don't need to take that glucose in your diet. The difference here is that you don't need it in your diet. It's true that you do need glucose in the blood, otherwise you cannot survive. But you don't need it from the diet. We do know, it's well established, that the liver makes glucose by itself. The blood sugar levels can be maintained by glyconeogenesis, which is the formation of glucose from proteins and fats. So the need for glucose can easily be covered by the body, and the red blood cells and the eye can function properly. Now, there is this misconception that the brain needs glucose, and we do have something called hypoglycemia, which is seen in diabetes also, because the treatment doesn't match the carbs intake, and the patient may go into hypoglycemia. It's a state we don't want. So if you are used to the normal diet, the standard diet, for instance, the standard American diet, the SAD diet, or whatever is eaten in modern homes today, well, in that case, it's true. If you go into hypoglycemia, your brain will have troubles keeping track with things and making it work properly. That is completely true. But that is if you're on a normal diet. If you're not on a normal diet, your body will start utilizing the fat for energy, and the ketones can actually be used for fuel for the brain. So for the brain, glucose is not required. Now, let's come back to this again. So rather than adjusting the amount of treatment to the amount of poison, maybe you should just try to reduce the poison as much as possible. If you reduce the carbs, rather than the 75 grams or 200 grams per day or 75 grams per meal that the ADA recommends, American Diabetes Association, rather than going with that, maybe we should just try to absolutely minimize the amount of carbs and let the body produce the carbs that it needs. If we don't take in carbs, our need for insulin will be less. If our need for insulin is less, the risk that we will underestimate how much insulin we should take, how much is being absorbed, how much carbs are we actually taking in. The risk of or overestimating simply is far less. So say if you were to take in a meal 10 grams of carbs, that could be that the label is again 25% off. In that case, we are looking at roughly 7.5 grams of carbs, and 20% off. We are looking at 8 grams of carbs, and we are looking at 10 grams of carb, and maybe if the label is 20% less than it should be, then we are looking at 12 grams of carbs. But for that, we might need just 1 unit of insulin. So even if we take 25% off the insulin dosage, we're still looking at a very small number. is 0.75, is 0.85. In all three scenarios, we would actually be reaching our target much better, and the risk of hypo and hyperglycemia is far reduced. Now, this is just an appetizer. We're going to talk about this in our separate video, where we talk about type 1 diabetes and low carb, high fat treatment of type 1 diabetes. So do watch that video also. And I'm Dr. Mazhar Hussain. We've been talking about the traditional way of managing type 1 diabetes. Do subscribe to our channel, click the notification bell, do share this video with your friends and families so that they're also updated on what the situation is on type 1 diabetes, traditional management, and do also watch the next video. Thank you.